to get started. Welcome to our December Dean Seminar. This is our last one for the year, so we'll take a break and resume in the new year in January. And I'm really excited to first meet and then also get the opportunity to introduce Kirsten Bibbins-Domingo. And it looks, a lot of you look like different faces than we normally see. So my guess is most of you already know her and she doesn't need a huge introduction. But this is actually a center I'm not familiar with, so many of you might be familiar with the Center for Vulnerable Populations here at the General Hospital. I was also excited about the timing with your recent being featured on the UCSF website with the science of sugar. And so I think this is a really relevant and important topic, and I think San Francisco General Hospital seems to be taking lead nationally. As many of you probably know, you're very well published with 113 publications and numerous grants, and you're going to tell us today about one of your brand new recent grants. So it sounds like you're willing to have this be informal and interrupt if there's questions. Yes, we'll have time for questions at the end as well. And if any of you that haven't been involved much in the Dean Seminar have topics that you might be interested in seeing in the new year, we still have a reasonably open schedule, and I would love to take suggestions of what you'd like to see at the Dean Seminar and what we can get out of it so that it's meeting everybody's needs. But it's mostly a avenue to see different departments and meet new people, generate research collaborations. So far we found that it's amazing how much overlap in the research in the different departments we have here at the General Hospital, and sometimes it's just hard to meet the people that are at the campus because the buildings make no sense. So, anyways, please feel free to contact me afterwards. My name's Chelsea Bainey, and Clara Cook helps us as well, so feel free to talk to either of us if you have suggestions. And welcome, thank you so much for talking.
Great, thank you. I am really thrilled to be here and great to see so many friends in the audience. So I would love this to be informal, and which means you should interrupt me if you don't understand something or have questions or think something is crazy that I say. I've been here at UCSF for a long time, since 1989 when I started here as a student. I started here at the General, working with Dean during my first year of medical school and right after my son was born, and he's now 19 and at Cal. So it's a pleasure to be here, and it's a pleasure to talk with you about the research at CVP. So here's our problem. This is what we're interested in tackling, disparities in health. Each of you probably have some idea of disparities in health and what that means to you. Here's one visualization that I like from our Department of Public Health. This is from Tomas Aragon. He did this nice analysis showing the causes of premature mortality. This is why people die before we would normally think they should die based on sort of average life expectancy in the population. And there are several things. So so these are the populations: African Americans, Latino, Asian, and white, represented here. Anything that is to the right of 0 means it's a premature cause of death. So you can see here that every group dies to some extent prematurely because of ischemic heart disease. And then as you look more to the right, you see African Americans in that circle lose many more years of life prematurely from these leading causes, right? And then when you look down the list at the causes, there are ischemic heart disease, HIV/AIDS, pulmonary diseases, cerebrovascular diseases, hypertensive diseases, and then self-inflicted injuries, overdoses, and assaults down here. What I'm interested in is that the first 5 essentially are sort of the medicine diseases, 4 of which are chronic diseases. In fact, HIV/AIDS you could put in the chronic diseases category, and that's what we're going to be talking more about. So if we were trying to improve health in San Francisco, we would want to go through this list and target this list. If we were trying to improve disparities in San Francisco, we'd want to move people who are more on this side over closer to the middle. Does that make sense? So here's the challenge if you're interested in the disparities angle. I just returned from a national meeting on disparities, and it's always great to hear the national leaders, how they put it. And this is Dr. David Williams, who's at Harvard. He said, our challenge when you're interested in disparities is that in order to address disparities in health, You have to continue to improve everyone's health, because that's what all of our goals are. And then you've got to improve the health of the most vulnerable at a faster rate, because that's the only way they catch up, right? So these are twin goals, but to do this, we've got to work doubly hard, right? Because that's the groups that are our outliers. And that's the groups we focus on in our center. So the CVP mission is we're the Center for Vulnerable Populations, and we're dedicated to improving health and reducing disparities through discovery, innovation, policy, advocacy, and community partnerships. We're a research center, but as you'll see, we think that our research extends into many arenas that require us to engage actively in policy, advocacy, and community partnerships. We seek to develop effective strategies to prevent and treat chronic diseases in communities most at risk. We don't actually define communities most at risk any more specifically than that. Sometimes it could be race, ethnic, minority status. Sometimes it could be poverty. Sometimes it could be specific factors like limited literacy or immigration status. Sometimes it could be factors that make someone extremely vulnerable to poor health, like being homeless, for example. So there are challenges to thinking about this broadly. But we think there are advantages because there are, I think, opportunities for synergies and thinking about common solutions to problems across groups that are defined by different vulnerabilities. And as you'll see, we have sort of a sprawling research portfolio as a result of this broad definition. Questions about who we are and what we do? All right, so I want to give you a framework for trying to understand research in this context. And this comes from Paula Braidman, who's one of our UCSF faculty, who also spoke at this conference. And this was a really nice conceptual framework from my perspective that she put together for the Robert Wood Johnson Foundation. So again, our goal is to improve health, right? Our goal is to increase health. The common ways we think about this have to do with medical care. We're here at a hospital, many of us are doctors. Our way of improving health has to do with the medical care of individuals. And it also obviously has to do with behaviors, what individuals do themselves that is clearly related to their health. And that's generally the way in our research framework that we've approached health-related research. But there are other things that are obviously important because both behaviors and medical care occur in the context of the living and working conditions of individuals and communities, right? So these things don't happen in isolation. We know that from how we care about individual patients. We know that for what our patients decide to do or not do. That much of this is still informed or guided by the types of places they live, where they work, those influence these types of choices, decisions, and actions. They also limit then sometimes what we can do in the medical care setting. These are also then sort of framed by the larger economic and social opportunities and resources. And so the way we think about health-related research in this context has to recognize these social determinants of health. These are absolutely critical. So even though we focus our research in this domain, they always have to extend out to these other things. They have to, because we don't get anywhere unless we accept, acknowledge, address the social determinants of health that sit on the outside of this. And then it's worth, of course, mentioning, from those of you who come from a biological mechanism perspective, that the relationship to health also works through understanding the genetic and biological factors that predispose people to health and disease. And we think about those things as well. So within this framework, what I would like to do is to tell you about a few recent papers from CVP and about our current research. And I'm going to focus in four domains sort of related to that conceptual framework. I'm going to talk about some of our research in the medical care arena. I'm going to talk about some research that's related to health-related behaviors of individuals. I want to talk about our interactions, work that we are looking at interactions with biological factors, and then talk about health communications generally, because that's a big focus area in our center. All right, so we are one of the 21 safety net hospitals in California. They, just so that you know what this system is, we're located in, the safety net hospitals are located in 15 counties where 80% of Californians reside. Safety net hospitals take care of lots of patients in California. And they take care of patients across the entire spectrum of care, continuum of care, inpatient, outpatient, and in behavioral health. Importantly here is that they provide the majority of care to patients who are on Medicaid or uninsured. And so a focus for us when we think about the healthcare settings is that if we want to improve health of the populations that are most vulnerable, we want to be able to understand how the medical care is delivered optimally in the systems that take care of them mostly, right? So that's the focus on the safety net hospitals, and being here at a hospital that has a long tradition of thinking about medical care, thinking about research on how to most effectively deliver medical care to vulnerable populations provides sort of an outstanding opportunity to both innovate, research, and then ideally disseminate. All right, so many of you may be familiar with this paper, which was published in October of this year, Support from Hospitals to Home for Elders. This was published in the Annals of Internal Medicine. This is an SFGH homegrown randomized controlled trial, one we're very proud of. Marga Kushel anchored the evaluation committee and is one of our faculty, as is Urmimala Sarkar. And an outstanding paper, and you may be disappointed to know that I'm going to lead with a paper that has a negative result. I'm going to cut to the chase, and it has a negative result. But it is one, this is our one, this is a, our premier journal in internal medicine, so it's an important paper nonetheless. So here is the premise of this trial. Hospital readmissions are a major concern. They're a major concern for patients who don't like to come back to the hospital, and they're a major concern for health systems because they often represent something that we could have done better in care for them to have to come back, right? We're particularly concerned in older adults of avoiding readmissions. And the concern about readmissions generally has discussions about this take place on lots of policy levels, and there are lots of penalties associated with the readmissions because of the concern that this represents, to some extent, suboptimal care, perhaps. But importantly, we just don't want patients to have to come back to the hospital. We like patients to live outside the hospital. So this was a large grant from the Gordon and Betty Moore Foundation that funded major projects at San Francisco General Hospital to reduce readmissions. That was the goal. And it gave money to also conduct this evaluation of this particular intervention. So this was a trial. 700 people were randomized. This was a randomized controlled trial of a nurse-led discharge intervention to reduce readmissions. The participants were English, Chinese, and Spanish-speaking older adults. They were 55 years of age or older, admitted to the non-surgical, non-psychiatric services here. The intervention was adapted for one that had been studied already in Boston, and it included one-on-one self-management education given by a language concordant RN, follow-up by a nurse, by telephone by a nurse practitioner, a warm line to answer questions post-discharge. The outcome in this trial was hospital readmissions and ED visits at 30, 90, and 180 days. And the combination of follow-up, and there was a combination of follow-up phone calls with extensive administrative data from area hospitals to make sure that readmissions that didn't occur here, we could capture those as well. So, a few things to know. I've already given you the punchline, but a few things to know. There was, as you know from taking care of patients here, there's a considerable burden of illness here in this hospital, but the overall rates of readmission were low. Yes?
I'm sorry, can we go back a slide?
Sure.
The control group in this, where did the intervention stop? Did just the education piece, or the follow-ups, or the warm line, or the?
I think the control group had the usual discharge instructions and
access to telephone follow-up in the warm line, or not?
I don't think so, no. I think this was access to the way we normally give discharge instructions, which would be, we make an appointment with the primary care provider, and if you go to Bridge, the standard way we give, I think we give a number.
Okay.
This is a sort of a little bit more active outreach,
Well,
that when
was
you
my
call,
question.
you're going to pick up, you're going to hear someone on the other end of the line. Yeah?
Was this the SHE project?
Uh-huh.
Okay.
You know more about the SHE project. Right, sorry, this is the SHE project. So important to know that there were overall low rates of readmissions. That's always challenging in a trial because you now have to see differences between the two groups, and if they're lower than you expect, now there are no differences, as we're going to get to. The patients had access to ambulatory care at the outset. That's another thing. These are patients who are tied in. So that means the people in the control group, if they have access to the outpatient care, that means they don't need the nurse potentially and the other things because they have access. They can figure it out. It's easier to do these studies if you go to somebody who has no access, and essentially you're expanding their access by providing all these other sets of interventions. So, but within the context of these two disclaimers, this study showed no difference in ED visits or readmissions in the usual care versus the intervention group. And in fact, it showed a suggested increase in ED visits in the intervention group. Right. The great thing about these investigators is that they used all their data at their disposal to try to figure out sort of what was going here. So they wanted to examine the characteristics of older adults in our hospital, to look at risk factors for readmission, risk factors for mortality, and the patient experience, and what patients say about why, what's important in their admission and readmission. So patients, interestingly, when asked, they talk more about the social and structural factors than the medical factors when discussing the risk of readmissions, right? There are high rates of functional and cognitive impairment at younger ages in our cohort. Even though we go down to 55, many people will say, well, this should be older adults. 55, by many people's definitions, wouldn't be older adults. In our hospital, many of our 55-year-olds look like 80-year-olds. So there are high rates of functional and cognitive impairment, even at this cohort that skews towards the younger age of what you consider older. The intervention did not have an effect on patient experience measures. So patients didn't experience the system differently as a result of these things. And then, importantly, those with the highest rates of social support appear to be protected from readmissions, right? So this is, again, talking about those social determinants, those other ways that we live that are important and influence health, that the medical system sits within, right? People who have those social supports, not surprisingly, are the ones who don't get readmitted to the hospital. And patients, when you talk about what things are important, it is things about the social and structural factors, right? It isn't about their medical care and the type of test that they were supposed to get. So what does this mean? This is a negative study, but it's an important study. And it's a study that says, if we are going to, as a hospital, think about this, as a health system, think about how to prevent readmissions, we have to think about what other things we have to take into consideration to do this. It also says that as we think about what types of policies penalize or incentivize these types of things, this is challenging for our setting because many of these factors are obviously not directly within our control in the healthcare setting.
So
yeah.
If I understood correctly, it seems like when you're saying the medical condition or the severity or the biology of the individual person didn't seem to be there wasn't a consistent, this group was sicker or had
Right. So the idea of doing this in a randomized fashion is that the degree of medical severity should be roughly equal between the two groups because of the way we randomized. And there's no difference in the outcome between the two groups, so on average. When you do the post hoc sort of analysis and you just look at what types of factors predict it, having more social support. But it didn't appear to be like the medical illness that was the key driver here. It also shows the importance of studying, right? This was a really important intervention, and it took a lot of man and woman power to pull off this type of intervention. And you also have to know, well, what works and what doesn't work, and you have to study it, and that's what we think is important as well. So the conclusions here, it's very difficult to move the bar on readmissions. Safety net patients face unique barriers from home environments and conditions of poverty. Hospital-based strategies may not hold the answer by themselves. And figuring out how we focus on bolstering social support and coordinating with ambulatory settings is really critical. This is our CVP team. It's part of our CVP team. You can never get all together in the same room. But I have this picture here to sort of highlight the fact that almost all of us are engaged in projects of some sort related to safety net settings, and particularly to innovations in our hospital. We're very interested in the rigorous evaluation of what we do so we know what works. We're also interested, we know that what's happening right now in our healthcare landscape is that there's a lot of interest in health information technologies, in the electronic health records, in patient portals, in devices and ways for patients to use health information technologies to engage more in their care. One of the things that our group, our colleagues in our center have been interested in is making sure that the most vulnerable patients aren't left behind in these discussions, because it's too easy to say, well, these are sort of luxury items and we don't do those, our patients can't do this, our system can't accommodate this. Are there ways in which these types of things actually create more efficient economies of scale, more efficiencies in the system, allow patients to more directly interact with our system that could be actually beneficial and help accelerate improvements in their health, and how do we know that and how can we study that? So I'm going to talk a little bit more about Urmi Mala. You know Nita Ratanawangsa. She does a lot with our electronic health record and has a K award to study the rollout of electronic health records in safety net settings and how that works. Courtney Lyles also has a K award. She's very interested in the patient portals, which I understand have opened up this week, which is very exciting. I'm going to talk more about Nita's work. Delphine Thuot is one of our nephrologists who is very interested in health coaches and has an intervention. And then in our community health system, you probably know her from CKD, self-management groups. And Margaret Handley does a lot with implementation science and evaluation. And we are wonderfully, strongly supported by our fantastic administrative team, Purva Chatterjee, Lita Tua, and Gato Gurley, who's here filming today. So I think the work that many of us have done in this area has led to our involvement in the national scale and sort of setting the standards for what we should do nationally. This is work of Dean Schillinger, who was the senior author on this important paper from the Institute of Medicine, who basically, in recognition of his work really, that health literacy is really at the heart of many challenges that our patients face in the healthcare setting, that any patients face within the healthcare setting, quite frankly, but more specific challenges in our patient context. Health literacy, while we identified as a problem for patients, is actually a problem that the system is not communicating effectively to the patient. That's the problem. And so he identified with his colleagues 10 characteristics of well-functioning health literate organizations. These are characteristics that systems have to have in order to deal with patients who across the whole range of health literacy spectrum. So a leadership that promotes these values, plans, evaluates, and improves, prepares the workforce to deal with health literacy, includes the consumers, meets the needs of all, importantly communicates effectively, ensures easy access, designs easy-to-use material, targets high risk, and explains coverage and cost. And I think this paper has been extremely influential in the field. I had the good fortune of recently serving on an IOM committee chaired by Nancy Adler, that in recognition of some of the things that were highlighted in that paper about the social needs of our patients, really this IOM committee basically was tasked with identifying what social factors should be included in the electronic health records. As a next wave of meaningful use, there's a suggestion that these factors would actually be included in health records, not to sort of annoy us and be one more thing that we collect data on, but in the ideal world, could we imagine a way we could identify risks, social and behavioral risks, and somehow link to Department of Public Health programs, other community health programs, and identify people really at the point of care so that we have a more integrated system at discharge. This was just actually released, and we're really excited to hear about the feedback, and we spent a lot of time thinking through which factors would be the short list of things you'd want to know, things that were actionable and related to health, and this is being discussed in, I think, a lot of circles about routine inclusion in electronic health records. I want to focus two recent efforts that will be led mostly by Urmimala Sarkar. This one in particular, this is a center grant that Urmimala just received from the AHRQ to create a center for ambulatory safety and innovation. And this is a grant to create essentially a patient safety learning laboratory here at San Francisco General Hospital. This center is called Ascent. And she's using sort of the latest in patient safety, reliability science, design thinking, and operational leadership to create and collaborate in this center to create creative and effective solutions. I want to describe the three projects that she has in Ascent. The first is to look at the most effective way to assure timely, accurate, and active test result management, a big issue for us on the ambulatory side. Thinking about population management to monitor high-risk conditions and treatment, right? Another of the big challenges in the ambulatory setting. And then thirdly, improving medication comprehension through plain language instructions. So three areas where there are big sources of potential errors and patient safety issues. And she has research projects in each of these three domains that are really housed within her new AHRQ center. And I think we're obviously extremely proud of Urmimala, but this is one of 5 centers nationally that's looking at these issues, and it's great to have it here. The other thing that's really exciting, as you know, we always think of our hospital as a leader in this area, and we are. And one of the things we are also excited about is that several of our faculty have with an initial grant from the AHRQ, developed a partnership called Phoenix, which is across the other safety net systems in California. And the idea here is that this is a collaborative agreement, a self-sustaining network, so that when we find and identify best practices, we can implement them and disseminate them across a network of safety net hospitals. So that the reach isn't just if we figured out what works for us, but we can share that with the other safety net hospitals. And I think Phoenix offers a lot of opportunities for us to think about additional collaboration and a platform for additional research. All right, so we've spent a lot of time in this quadrant, medical care, because that's, again, where most of us are doctors in the center, that's what we spend a lot of time doing. Let's switch a little bit to behaviors. And here I want to highlight the work of Hilary Seligman, who's in the audience, and this is a paper that she and Dean Schillinger co-authored in the New England Journal. Hilary's work really focuses on food insecurity, not having the resources to have either enough or high quality foods. And as you know, diabetes is a condition that's highly sensitive to the types of things that you eat. And she developed this very nice conceptual model for how food insecurity might interact with diabetes. So food insecurity is related to the affordability of healthy foods, which we know are important for diabetes prevention and management. It may be associated with episodic food availability and obviously stress surrounding this. These factors can lead to poor diabetes control, increased diabetes complications, increased health utilization and expense, and then worsening of those competing demands now when you're juggling health expenditures and food expenditures. And so she's done a lot of work in this area of food insecurity and really defining it in the context of diseases that we care about as well. And I want to highlight this paper of hers that was published at the beginning of this year in Health Affairs. And this came from an idea that she had that basically for people who have limited resources, the end of the month can be a challenging time, right? Whether those resources are your disability check or your work check, that if you're relying on living month to month, that at the end of the month, resources run out. And that as resources run out, people who have to make decisions in the environment of scarcity might make decisions that could have health impacts. And in particular, what she focused on here is on admissions for hypoglycemia. So hypoglycemia is too low blood sugar. The hypothesis here is that if you're a diabetic person, you're facing those competing demands I described on that flow chart before, you reach the end of the month, there may be ways in which you alter your diet compared to the beginning of the month as you face those challenges. If you're continuing to take all your meds the way, hopefully, we hope our patients do, that if you actually are not eating the way you think the way you started to at the beginning of the month, then this might lead to admissions for hypoglycemia. Admissions for hypoglycemia are relatively rare, although they are on the rise as we're tightening our control of diabetes. So there's a lot in the literature about hypoglycemia. This is Hillary's evaluation of essentially California OSHPA data. This is discharge data from the state of California. What you see here, so across all states, across all the hospitals in California are all discharges. What you see here is the days of the month, right? And you have rates over here. These are rates of admissions. And what you notice here in this top squiggly line is these are the lowest income individuals. They're actually individuals whose zip code links to the lowest census tract, the lowest income census tract. And what you see here is that this pattern, wavy pattern, at the end of the month, the last 4 days of the month, the people who have the lowest income have a spike in hypoglycemia admissions. The same is not true of people who have adequate incomes. And the same is not true for things like appendicitis, which we wouldn't imagine would be sensitive to how much money you have in your pocket, right? So 27% increase in hypoglycemia admissions during the 4th week of the month compared to the 1st week of the month in people who have limited incomes, right? So, I mean, when Hillary first wanted to do this project, I was like, that'd be amazing if we could see it. And the fact that you can see it is pretty striking. And the fact that you can see it is pretty striking, and it also means that this is real. This is real admissions. This is real disease coming into our hospital, real burden on our patients, directly related essentially to income and then food insecurity. Yeah?
What are the readmissions? So, same patient getting admitted 3 times, 4 times.
Are these distinct individuals?
Correct.
There's no way to know it.
So hospital admission, so same patient could be getting admitted.
Yeah, I don't know. Yeah, it's a good point. Interesting. This paper got a lot of press. There are a lot of people interested in it, ranging, people who are interested in, benefits for food stamps, SNAP benefits, those types of things. But also people in the nephrology community who are really interested in their oftentimes lower income patients, very concerned about hypoglycemia because of the interaction with kidney disease. and very concerned about the admissions for hypoglycemia. Hillary has done other work looking at other ways in which our food policy are related to the risk of type 2 diabetes and obesity. This paper talking about the subsidies in SNAP for sugar-sweetened beverages. This is some of my work looking at the potential for taxes on sugar-sweetened beverages to cut healthcare costs and reduce the burden of diabetes. You can see that a lot of this work around food and its intersection with health leads us to be forced into this policy arena to think more about both SNAP benefits and how those are used to stave off food insecurity, as well as assuring the most healthful diet for the individuals we're interested in. So as a result of this policy work, Hillary was recently awarded this grant from the CDC. This is the Nutrition and Obesity Network Policy Research and Evaluation. This is the coordinating center for the Centers for Disease Control for their nutrition and obesity policy work. This grant was just awarded. This coordinating center site had been at Harvard for many years, and now we are fortunate and quite frankly a little bit scared because it's coming here. But I think the thing that's made me really excited about this is that the investigators involved in this are really excited about this. They really love the work that's going on here. This is a group of passionate individuals across the country who are thinking about the types of policies related to nutrition and obesity and how that's related to health. There are several work groups here related to water access, early childhood education, rural food access, and the CDC believes strongly in these academic partnerships for more dissemination of research into local implementation. There's a conceptual framework about identifying policies, developing policies, evaluating, and then coming back to the translation, communication, and dissemination. And we're just getting off the ground with this. I also want to highlight another great project that Hillary is leading. This was funded through a lovely grant from the Hellman Family Foundation that was looking for good ideas that would have an impact of the health in San Francisco. And this has been Hillary's longstanding interest in weekly fruit and vegetable vouchers. As you might know, fruits and vegetables cost relatively more than other types of food items. And so for people with limited incomes, it's often the thing you trade off, right? Because there are other things that you can get your calories without expending the type of resources to eat the things that can be more healthy, like fruits and vegetables. So the idea here is to develop a voucher program essentially for a dollar value of $5 to $10 for fresh fruits and vegetables. This is a collaborative effort. Again, this was the initial money, but the Department of Public Health has been really behind this effort, and this really represents a collaborative bringing together of lots of community organizations led by the Department of Public Health and Hillary really to bring this team together. The idea is to first blanket neighborhoods to focus on, and we'll focus first on the Tenderloin, to distribute these vouchers to households with children and also to low-income adults with chronic diseases. The idea here is that the vouchers themselves drive the demand for fruits and vegetables, and that means that the vendors are more inclined to provide the supply. So you're increasing the purchase power for things that you know are healthy, and that hopefully stimulates then retailers to actually supply these. And because the retailers in San Francisco are part of the partnership here, it's a really nice model. Also just getting off the ground, you'll hear more about it hopefully soon. All right, so we talked a little bit about medical care behaviors. Those of you who like to think about biological mechanisms, I just want to give you something to think about as well. But any questions before I move on to that? All right. So this is a paper that I was one of many groups that contributed to this work looking at sickle cell disease trait and chronic kidney disease and the risk of albuminuria in African Americans. And we have, before then, been very interested in an allele called APOL1 and the risk of albuminuria in African Americans. As many of you will know, African Americans have higher rates of chronic kidney disease than other groups. This is whites, this is African Americans, and these are other groups here. Most non-white groups have higher rates of chronic kidney disease. The challenge in African Americans is not just that there's more, but it starts earlier in life. And it's a theme that you'll hear a little bit more about, our interest in focusing on that young adult period as a period of vulnerability. Because it happens earlier in life, there's a lot of interest in understanding what are the genetic factors that lead to this increased higher rates of chronic kidney disease. So in this study, which is currently under review, we were interested in looking at these genetic factors. APOL1 had been previously identified. It actually confers a comparative advantage in the setting of trypanosomal disease. So it is like sickle cell disease, a disease that you can understand evolutionarily why it would have increased in these disease alleles in frequency in particular populations that have their ancestral origin in Africa, like sickle cell disease. The disease, the high-risk alleles in APOL1 basically only occur in African Americans. You don't see them in other populations. And they have been shown by others to have an increase in the risk of albuminuria. What we wanted to do was understand these genetic variants and how they relate to traditional risk factors as well as to socioeconomic status when we understand kidney disease, albuminuria, in African Americans. Does that make sense? We know there's genetic factors, we know there are traditional risk factors like hypertension, and we know that poorer people have more chronic kidney disease. So we wanted to figure out how do those play themselves out. Yeah?
What are the numbers?
These numbers here, these are the years.
Oh.
Yeah, this is from USRDS. The government tracks because they pay for dialysis. They track a lot. We have a lot of great numbers on kidney disease, but that's the numbers are higher over time. Yeah.
It seemed like you were referring to some type of benefit that might have been associated with evolving with that particular trait.
Yeah.
Certain geographies or associated with certain populations. Can you talk a little bit more about what that potential benefit might have been?
Yeah, I have to say I'm a little out of my depths here, and I also think I think that there's a theoretical benefit. I don't know, but it appears, and I really don't know. It appears to right. One could postulate from the way this works that it would have conferred a benefit in trypanosomal disease. But I don't know that we know really more than that. It's just a hypothetical benefit. It is true that the high-risk alleles are virtually non-existent in populations that don't have sort of African ancestry, so African-American populations. And it is the hypothesis why sickle cell disease obviously increases for the malaria benefit, for the same thing. So
that's actually been shown.
Yeah.
The deformation of the cells in sickle disease prevents the multiplication of the malarial parasite.
Exactly.
And therefore it confers a benefit, a survival benefit on those patients who have sickle disease in places where malaria is endemic.
That's exactly right. And the theoretical thing is that this would work.
The theoretical is that in trypanosomiasis, which is also a protozoan disease,
yes,
the trypanosomes are particularly good at the transformation of their of their antigenic properties, and it may be that somehow that interaction with this allele would be beneficial.
Excellent.
That's
excellent. So glad you're here. All right. So here are the results, and this is work from Carmen Peralta, who's a nephrologist mostly at the main campus, and she and I have collaborated for a while. So, and this is a study in cardia. It's a young adult study. These are people in their 20s and 30s, it's an NHLBI-funded cohort study. Half of the cohort is African American, half of the cohort is white. They've been followed for 30 years, and we've done quite a few studies in here. So first, let's look at blacks who don't have the high-risk alleles and blacks who do have the high-risk alleles, right? You see here about the prevalence. This is a community-based sample, so you see here about the prevalence of the high-risk alleles. And then we're looking at the outcome of albuminuria. And you see here that those who have the high-risk alleles, these are odds ratios here, so have 2 to 3 times increased odds of developing albuminuria. I think these are actually hazard ratios, I don't say odds. Okay, so about 2 to 3 times the risk, yeah, by having this. This has been shown by others. Here, we looked at comparisons between whites and blacks. So now whites are the reference group. This is blacks who don't have the high-risk alleles. And what you see here is that blacks who don't have the high-risk alleles also have twice the risk of developing albuminuria compared to whites. The key thing here is it goes away once you add socioeconomic status. It says there's a big portion. This is a lot of blacks who don't have this risk allele, who have a higher risk of chronic kidney disease compared with whites, and whose risk can be explained essentially by socioeconomic factors, right? And then let's look at the genetic group, the smaller group. The smaller group has a markedly higher, 5 times the risk of chronic kidney disease compared with whites in this group. And that risk is attenuated somewhat by socioeconomic factors, but is still there, right? So this is a really powerful risk factor. Yeah. But importantly, when you look now in blacks and you say you have this powerful genetic factor, when you say on a population level, how much does this genetic factor explain? APOL1 explains about 9% of the risk of chronic kidney disease in that population. That's a hugely powerful predictor in the scale of genetic risk. Hugely powerful. The challenge is that much more of this risk is explained by the traditional things that we know, hypertension, diabetes, right? And the reason why we spend time to go through all this is because it's still important to put all this in context. So it's often the case that once we get a new genetic factor, there are a lot of people interested in, like, let's get the genetic test, now we know what to do, we can identify this high-risk people, we can do whatever. It's really true. You can do that for this proportion of the population. For the much larger proportion of the population, it's still understanding the socioeconomic factors as well as the traditional risk factors of hypertension and diabetes. Yeah? All right. We focus a lot on the chronic conditions in young adults, and we have 2 center grants that really focus on those. We focus on them because minority and poor communities get chronic diseases at higher rates, and they get them earlier in life, and that's important. This is a center that we have from the National Institutes of Minority Health and Health Disparities. We have 3 projects here related to asthma, gestational diabetes, and tobacco. I'm going quickly now. We have another one focused on hypertension and stroke in young adults. This is a collaborative center that we have with Kaiser. And so, now we've done all 3 of these. Okay, we're getting to time, but I don't have much left. I want to tell you because, again, we've talked a lot about the 3 of these things. But that because we sit out here and want to think about living, working conditions, larger social policies, we have to actually think about partnerships with community organizations, partnerships with to be able to do this work. And partnerships, too, to actually think about disseminating health messages. So I want to talk with you about one of our, really our just smashing successes led by Dean Schillinger, and this is the bigger picture. The bigger picture. How many have heard about the bigger picture? A few, all you guys I know. Okay, so I'll tell the rest of you. So the bigger picture is a partnership that Dean developed with Youth Speaks, which is a group that does youth empowerment through spoken word performance poetry, right? So the youth talk about their own experiences, they write their own poems, they write and they perform them themselves. Dean had the idea that if we talked to them about the health problems in their community and just talked with them about it, maybe they would be inspired to write some things related to health. And we focused on diabetes here. Why? Again, diabetes accounts for over 95% of the cases. It used to be found in only older adults, but now has been going to younger and younger people, particularly in urban and poor communities. These are the staggering numbers. 10 years ago, 1 in 11 people had prediabetes. Now it's 1 in 4, right? Those are staggering numbers. That's right now, yeah? And then 50% of African American youth and 30% of Latino youth will have type 2 diabetes in their lifetime, and that's only 25% of white youth, which is still way too high, right? It's still outrageous, right? And that's all about the food environment. Nothing changed in our environment over 10 years, except for this is not new genes. This is like other things, right? That's why we're interested in the policies. So the bigger picture has received rewards and recognition from the Institute of Medicine, the Association of American Public Health Association, and a recent award from the UCSF Community Partnerships. And there's a paper coming out showing that it actually, the impact it actually has on health. Now, I want to be able to show you what one of these things look like, so I hope you'll just indulge me. This is my next to the last slide. Do I need to do something, please? I don't know. Am I probably not connected to the internet?
That's why
Browser.
So this is one.
My grandpa flashes a gold tooth and he smiles, like I dare you to take something between my lips. His tooth shines in the light of the TV screen when my family watches telemundo during dinner time. While I practice my Spanish, Grandpa unhinges the English from his mouth, at least for a little while. This is how we both learn the impediment of marriage, through television. Tells us of our ancestors, how they raised maize and yucca from the earth, hand-steeped in indigenous soil. How as warriors, we drank cacao and water bitter from the gourd, a medicine sacred to the gods. Between growing up in Colón, Panama, and a tour in the U.S. Army, Grandpa is a proud old soldier marching through a never-ending war. At 66, we are scared that another stroke could do what no war ever could, and cut him to the ground. He drinks. My Aunt Maritza didn't lose both of her legs to diabetes last year. Like half of our neighborhood doesn't look like the emergency ward of a hospital, like he hasn't seen the pictures. How it is impossible to tell the difference between a roadside bomb victim and someone who just forgot to take their insulin. Grandpa keeps at least 2 12-packs of soda in the fridge at all times. Sunny Delight, Tampico, High C, a jug of Kool-Aid in the back. Dr. Pepper lines our refrigerator door like a vest of dynamite, an arsenal of ways for us to self-destruct. It is how you learn to drink, growing up in a country where soda is cheaper than clean water, where hunger is a canal carved deep into your belly, where the only options for work are the docks and the army, because your country is as occupied by Coca-Cola as it is by the U.S. military, When you must march to the call of whatever feeds family first, you drink whatever fits conveniently in your hands. I understand, Grandpa. But don't you know we are still in war with the country that wants us dead? How us children of Panama and America learn early to walk softly and carry a big stick like U.S. assault rifle in one hand, Coca-Cola bottle in the other. Our country wasn't enough. They're colonizing our bodies, our taste buds. It isn't a coincidence that military and beverage companies call us their target audience. Our black and brown bodies marching to the center of their crosshairs. At home, a Coca-Cola commercial followed by a U.S. Army commercial flickers across my grandfather's tooth, and they both shine like the discharge of a gun. I learned to drink like Grandpa, like Colon Panama, like $14 billion spent on soft drink advertising last year. The threat of diabetes is as common in our family as hard work, obedience, discipline. It is as common as Coca-Cola in our refrigerator, and we drink until the glass is empty. Because we ain't never learned to pull maize from the soil, but we did learn to pull the tab of a Coke can. Doesn't it sound like the linchpin of a grenade? Both explode under pressure. Ain't we just time bombs, baby? We march until they cut the legs out from under us. Ain't we perfect soldiers?
That just gives you an example of the types of things that, and this is all of the youth poets who've done this and have really received now quite a bit of recognition, and a lot of this has become both public service announcements as well as they've gone into the schools to try to do more education, and obviously youth voices speak the best from this perspective. So there's a lot going on at CVP. There are a lot of things I didn't have a chance to talk about. Some of our faculty do research in really our most vulnerable populations. Margaret Kushel works in homelessness. Christina Mangurian in patients with severe mental illness. We're really interested in global health as well, particularly Mexico, because there are a lot of local, global opportunities we've had, and we taught a course in Cuernavaca, Mexico just recently this past summer. And we're interested in training and have had received 2 grants recently from the NHLBI in implementation science, and then a large grant to do collaborative work with San Francisco State University that hopefully you'll hear more about as this gets going. What we're really interested in is a partnership between UCSF and San Francisco State in order to get state students interested in biomedical research, but also to research that's of relevance to San Francisco and their communities. And so I think you'll hear more, and hopefully there'll be lots of cool opportunities to do work between our 2 institutions. This is our faculty and staff. We couldn't do it without this large and terrific group. And then, as you can see, we like to write these collaborative center grants, and we like to do work collaboratively. And so there are many, 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 many more people who we collaborate with, faculty and staff and community through these collaborative grants. Check us out. This is our website. We are down on 25th and Potrero. We oftentimes have seminars, and we would love to have you come by. And if you have ideas for thinking about how you'd like to collaborate with us, that's one of the things we love to do. I think the purpose of thinking about a center like this is really to think about how not to be bound by traditional divisions, departments, whatever, but to think about how we can work collaboratively. And so